2, 1.
Hello everyone, thank you for joining us for our second orthopedic anatomy event. I'm Dr. Kevin Stanley, hip and knee surgeon at Ortho Carolina in Mooresville. I'll be your host today.
And I'm Rachel Klaus, academic program specialist at Experience Anatomy.
If you're tuning into this event series for the first time, we'll give you a little background. At Ortho Carolina, our goal in 2020 was to create a series of events to educate you on your anatomy and explain what actually happens to your muscles, bones, and joints when you're in pain. We set out to highlight a variety of orthopedic topics so you can get all of your questions answered by our team of doctors alongside the experts at Experience Anatomy.
For those of you who don't know Experience Anatomy, we are a premier anatomy education company specializing in training and education using real preserved human specimens. We are fully outfitted with a cadaver lab and human plastinets, which allow you to see what your muscles and bones look like under your skin.
With the recent changes in our world, we've adjusted this program to a complete virtual experience so you can tune in where it's convenient for you. The entire video will be available after the event. If you've missed something, you can watch it back and or share with a friend if you find the information helpful. Today we'll be discussing hip and knee pain, arthritis, and what that means when it comes to getting a replacement and what your appointment and potential surgery can actually look like. Warning, we'll discuss the hip and knee anatomy separately and want to err on the side of caution with this disclaimer. The knee portion is a bit graphic. We'll be showing a live look at what a knee surgery would actually look like using cadaver in a mock medical setting. We will let you know when to expect it.
This is a virtual event streaming live on Facebook and YouTube, so this is your opportunity to ask our hip and knee doctors anything. We've got a panel of physicians ready to answer your questions at the end. If you already know what you want to ask, comment on our live stream below or whichever platform you're watching, so we'll be sure to discuss.
Now let's meet our panelists. Dr. Michael Bates.
One of the hip and knee replacement specialists at Ortho Carolina. I practice in Charlotte, exclusively at the university location, although I operate in multiple hospitals in the city. I did my residency here in Charlotte, North Carolina. I did my fellowship in hip and knee replacement at the Hospital for Special Surgery in New York City. I've practiced for several years now. I truly enjoy what I do. I think tonight will be a great discussion about hip and knee arthritis.
And now we're going to go to Dr. Brian Curtin.
Good evening. I'm Brian Curtin at the Ortho Carolina Hip and Knee Center, downtown Charlotte. I've been in practice now since 2011. I actually did my fellowship here in Charlotte and then went away to the Medical College of Virginia for 2.5 years and then came back. I grew up in the Asheville area and was drawn to come back and really love the Charlotte area. I do primary and total hip and total knee, as well as complex revision and infection work at the Periprosthetic Joint Center here as well in Charlotte. And excited to be with everyone tonight and share our knowledge of hip and knee replacement.
We'll go to Dr. Henderson.
Hey everybody, I'm Drew Henderson. I'm another one of the hip and knee replacement surgeons. I work up at the Winston-Salem location. I see patients here in Winston-Salem and also up in Kernersville. I'm in my third year as a surgeon with Ortho Carolina. I trained up at Duke for my residency and then did my fellowship up in Philadelphia. My wife is born and raised in Winston-Salem, and that's what brought us back here. And I'm certainly happy to be part of this tonight and happy to answer any questions. I think it'll be a good opportunity.
And now to Dr. Prater.
Everyone, thanks for joining us tonight. Happy to be here. My name is Dr. Prater. I mainly operate out in Gastonia at our office there. Also, kind of like Dr. Bates, operate in several hospitals around the city, but that's my primary office location. Trained down in Georgia from a residency at the Houston Clinic, did fellowship at the Stedman Hawkins Clinic down in Greenville, South Carolina, and I'm happy to be here. Again, one of the hip and knee primary revision surgery, partial knee replacements, as well as some general orthopedics.
Let's take a look at our first segment with Dr. Bates as he touches on what to do when you have hip and knee pain, what your next steps might be moving forward when consulting with an orthopedic surgeon.
Hello, my name is Michael Bates. I am an orthopedic surgeon specializing in hip and knee replacement. I practice at Ortho Carolina in our University City location. So there are many reasons that folks come to see orthopedic surgeons, and one of the most common reasons is hip pain. There are many reasons you can have hip pain, but the most common that I see in my practice is due to arthritis of the hip, specifically osteoarthritis of the hip. Arthritis of the hip is a condition where the substance known as cartilage is deficient. Here is an example of the hip. Typically, the ball of the hip, known as the femoral head, has a substance on it called cartilage. The same substance is on the inside of the acetabulum. So when the hip moves, that coating prevents it from having pain. Now, if you are missing that coating for any reason, whether it be wear and tear, which is what osteoarthritis is, then as that ball moves in the socket, it becomes very painful. People usually experience this pain in their groin area. Sometimes we will have patients present complaining only of knee pain. However, the problem is actually in their hip. And we can figure this out with x-rays, but it can be really surprising for an individual when their knee has been hurting them for months. We take an x-ray of their knee and it looks perfectly fine. Next, we'll do our physical exam, and typically if the hip motion causes their knee to hurt, we'll then get x-rays of the hip. And sometimes we'll be surprised at just how much arthritis the individual has. If you have a little bit of subtle pain when you walk 2 to 3 miles per day, you probably have some time before you have to think about surgery. But on the other hand, if you can't play with your grandkids, if you can't get dressed in the morning without someone having to tie your shoes for you, that's when the hip arthritis is becoming more disruptive to your life, and it's much more reasonable to consider a significant decision like hip replacement. Commonly on the initial office visit, we will review x-rays with you, and we'll show you arthritis if there is some there. So, a few things that we'll do on the examination to try to confirm whether or not the issue is coming from your hip. Can you raise your right knee in the air and hold it up even if I push down on it? And when I push down, does that give you the pain again? What we're doing there is we're putting a lot of pressure right there on that ball and socket, which is why it's reproducing the pain. Another thing we notice with hip arthritis is people lose their motion. Typically, you'll have at least 30 or 40 degrees of rotation this way, and even more this direction. Now, this hip will probably have less because I'm suspecting there's arthritis there. That's about as far as I can get this hip, and it's probably starting to give you a little bit of pain right there. What I would recommend we do is take some x-rays so we can evaluate the hip joint, and then we can look at those together. And we commonly will see where the joint space between the ball and the socket has gotten narrowed, or in some places is no longer there. If that's the case, we'll usually make the diagnosis of arthritis of the hip. And we determine the severity based on how much of that joint space is remaining. If you've ever heard people say bone-on-bone arthritis, that means there's no joint space remaining. The bones are actually touching each other. But we can make that determination by looking at the x-rays. Now again, there are multiple ways that you treat osteoarthritis of the hip. We try to start with conservative measures first, but it's based upon the severity of the symptoms. Physical therapy can be effective for people. If we don't see severe arthritis, which you may hear some people refer to as bone-on-bone arthritis, that's typically where we're going to start. If that's not sufficient, then typically we'll add medicines to the plan, such as anti-inflammatory medications, as long as you're able to take those. The next step, sometimes we can consider an injection in specific scenarios, and in other folks, if the pain is really severe and we've been unable to make good progress with more conservative measures, we will talk to the individual about surgical treatment. That's hip replacement. During the surgery, we remove the femoral head right about here. This is taken off, and then we use a prosthesis which slides down the inside of the femur bone, and it replaces the ball here. On the other half of the hip, the acetabulum, you already have a socket, so what we do is put another socket inside of yours. So at the end of the surgery, we replace 2 painful surfaces with 2 new prosthetic surfaces. Typically, we try to have you up, out of bed, walking around not within days of surgery, but within hours of surgery. 2 to 3 hours is fairly typical. After you get home, you can shower within 1 to 2 days of surgery. We use special water-resistant dressings to make that easier. We may limit your return to athletic endeavors for several weeks after surgery, but things like walking are completely fine to do right away. Now, when it comes to knee replacement or knee arthroplasty, there's two common variations. There's total knee replacement and partial knee replacement. Now, in the hip, there is a such thing as partial hip replacement, which we call hemiarthroplasty. However, for the typical person who has osteoarthritis, the treatment is total hip replacement. Typically, partial hip replacement or hemiarthroplasty is reserved for folks who have a hip fracture, not the standard reason a person is going to be coming into the orthopedic surgeon's office. So another common question I get is, how long will the implant last? Years ago, we used to tell people 15 years or 20 years. Fortunately, in the past 15 years or so, there have been some significant changes in how the components of hip replacement are produced. And that has led them to be dramatically more resistant to wear and tear. Therefore, we don't really worry about these hip replacements wearing out nearly as much as we used to. I have complete confidence when I tell patients we expect you to get much more than 20 years. For that reason, we now offer hip replacements to younger patients. We used to be concerned if a person was in their 40s or their 50s with a hip replacement, because if it lasted 20 years, when they were 60 or 70, they had to have another surgery. That's much less common a concern these days because the implants are so much better. That has opened up this surgery to younger patients who have severe arthritis, and we can do so without them having to be so concerned about having to have multiple surgeries later on. So the bottom line is, if you have pain that's concerning you, don't ignore it. Basic x-rays are easy to get. We can give a lot of information pretty quickly and hopefully just reassure you. But if there is something more going on, we can provide you with answers and options.
Yeah. All right, great job, Michael. That was a very good presentation. We thank you for doing that. We've got a couple questions already. We're going to send one of those questions to Dr. Prater. They asked, one of the call-in questions asked, does osteoarthritis get worse as time progresses?
Yes. Typically, the way to think about it, and that's the way I kind of describe it to my patients as well, ultimately, it does get worse as time goes on. There's really not a whole lot that can be done other than, kind of maintain a healthy lifestyle and trying to stay active that can slow it down. But the things we try to do to kind of help is mainly just symptomatic control.
Excellent. We had another writing question. They said, what are the latest advancements in total hip replacement? I was wondering if Dr. Henderson could comment on that.
Yeah, so a couple things that are, I guess, sort of newer in the past few years. One is I think the metals are much better, and specifically things like cross-linked polyethylene, which is a type of plastic we use in the implants, is I think a big part of why Dr. Bates mentioned that hip replacements are lasting a lot longer. I think the anesthetic techniques for hip replacement are much better than they used to be. And that's enabling people to get up and walk, as Dr. Bates mentioned. And, even some centers, including a lot of the folks at Ortho Carolina, are starting to do some outpatient hip replacement, which is kind of an exciting new frontier. I would say lastly, people are experimenting with different surgical approaches, and that's, I think you'll see from the panelists, probably a source of some debate, but certainly the way we do surgery is getting less and less invasive over time.
Excellent.
I've got another question.
Oh, yeah.
We've got one more question here that just came in, is what sort of physical activities can one expect to do after a hip replacement?
We've got one more question here that just came in, is what sort of physical activities can one expect to do after a hip replacement?
Sure. I typically let my hips probably do a little bit more than my knees. In terms of hips, I really don't have restrictions in terms of what they do, other than I typically don't want them running marathons or playing in basketball leagues. Other than that, they can pretty much do most of the things they want to do. And I usually tell most patients by 6 months, you pretty much forget you've got a hip replacement for the most part. So no real limitations on a hip. Most patients by 6 months, you pretty much forget you've got a hip replacement for the most part. So no real limitations on a hip.
Great, thanks, Brian. We're going to go to this next segment now. This is the anatomy of the knee. And this is Dr. Curtin showing some anatomy. And this is going to be the part that may be a little bit graphic. There's a cadaver in there, so if you're not sure about it, just turn away for a few minutes, and then we'll come on back and we'll answer some more questions after that. Graphic, cadaver in there for a few minutes, and then we'll come on back and we'll answer.
I'm Dr. Brian Curtin from the Ortho Carolina Hip and Knee Center, practicing hip and knee surgeon as well as revision surgery. I have offices at the Hip and Knee Center as well as the South Park office. So today we have a 54-year-old male knee that we're going to kind of dissect and kind of take a look at what's going on inside the knee. The main reason why we do hip and knee replacements these days is for arthritis. And arthritis is basically just wear and tear of the joint. The cartilage gets really thin. I like to compare it to tires on your car. You know, the tread on the tire goes bad, not so much the wheel, but the tire itself. And that's the case with a knee, where the cartilage goes bad, not the bone itself. Most patients come into the office and they don't know they have arthritis until we get an x-ray and really evaluate their knee. And at that point we can tell, that you've worn the cartilage of your knee. You don't jump straight into surgery. There's a lot of conservative things that most patients can do, typically for years, sometimes before any surgical intervention. But when you get to the end of the road and you've sort of done all of those conservative options, then you got to start looking at surgery. A lot of it is based off of symptoms, and when it gets to the point where it's affecting your daily activities, when you can't go out with your grandkids, or you can't walk more than a block, you're starting to use a cane or a walker, it's waking you up at night. That's probably the biggest complaint that I get from patients when they're ready to pull the trigger and get their knee replaced, is they can't sleep at night. The morning of surgery, you'll come in, you'll do some things that morning in terms of cleaning the skin. They'll do some clipping of any hair that may be on the skin to make sure that your risk of infection is very low. And then we get you back to the operating room. At that point, there's various ways of putting you to sleep. Most patients are pretty much taking a full nap while they're having their surgery and don't know of anything that's going on. Most of the time these procedures are done under tourniquet to decrease blood loss. So that tourniquet goes on the upper thigh. Typically the way we start these is a midline incision right over the front of the knee. And we're going to start that usually about 2 fingerprints above the top of the kneecap or the patella. And we're going to come straight down right across the front of the knee. And we follow this down right to the fascia layer, which is just sort of the outside covering of the knee joint itself. And that kind of holds in all the joint fluid that helps lubricate your knee. So as we enter the knee, we come down and we basically open up where the subcutaneous tissue connects with the fascia and really expose the full width of basically your whole kneecap. We have access to what's called a medial parapatellar arthrotomy, and that's how we actually get into the joint itself. And what we do is we come right down through the quadriceps tendon and enter the joint. And usually at this point, especially in a very arthritic patient that has a lot of fluid that's accumulated in the knee, you'll actually get a big gush of fluid because a lot of times that fluid is under pressure with an arthritic knee. And that's what patients feel with that tightness when they bend their knee, is a lot of that fluid in the knee joint itself. And then we actually do a little bit of a release on the medial capsule, and that's going to allow us to expose the knee even further. So one question a lot of patients have for me is, what exactly are you putting in my knee with a knee replacement? And I usually tell them we really should call this a knee resurfacing as opposed to a knee replacement. Everybody always thinks that we just kind of hack out from here to here and put in a big hinge replacement. Well, it's not really the case. We're actually capping the ends of the bone where your old beat up cartilage was, and we cap it with metal and a piece of plastic in between. Now I'm up into the quadriceps tendon a little bit. In order to expose the full knee, we can actually flip the kneecap over, and you can actually see this patient actually has some cartilage damage on the back side of the knee, but this would be sort of grade 2 changes of the patella or the kneecap. So once we've got this exposed, then we bend the knee up, and then we start making our cuts. And we actually basically just make cuts along the ends of the femur, and as well as the tibia, or the tibia bone here, the femur bone here, that actually serve as a surface that we cement on, or some implants that actually press fit and your body grows into the back of the implant. The meniscus is actually sort of in here in between those two. Some patients will have some pain based on that. That's usually a younger patient that's had a small injury of some sort and they've torn that meniscus. Almost every patient that has bad arthritis has a torn meniscus. So this is the knee flexed a little bit, and you can see the cartilage on the end of the femur over here. This patient's ACL is still intact, as is their lateral meniscus, which is deep down on this side. They've actually pretty much torn a good portion of their medial meniscus. That would be removed during a total knee replacement procedure. But this cartilage actually looks pretty good. This is the early stages of some arthritis with sort of what we call bone spurs or osteophytes. You can see those right up here. These don't belong there normally. That's your body's way of actually saying the force across this joint is not normal. So it tries to build the surface area out to distribute that force a little differently. A lot of times patients will ask me, am I a candidate for a partial knee replacement or do I have to have a total knee replacement? A lot of that depends on your x-rays, your clinical findings, where your pain specifically is. And the thing about a partial knee replacement is there's three compartments of the knee. You got the medial compartment, the lateral compartment, and the patellofemoral compartment. If any of those three are isolated disease, then you can just replace that compartment and not replace the other two. I would say probably 10 to 20% of patients are possibly candidates for a partial knee replacement. In those cases, you essentially just go in and replace this section of the knee and this section of the tibia on the other side with metal and plastic. That does retain the lateral compartment and the backside of your kneecap. It feels more like a normal knee. You bounce back a little faster, shorter incision. I usually say it's 4 to 6 week recovery on a partial knee replacement versus 6 to 8 on a total knee replacement. Once we've got our implant cemented in place, we typically have about 10 minutes or so waiting for the cement to harden, and then we let the tourniquet down. And at that point, we make sure we catch all the little bleeders and make sure we don't get a lot of bleeding into the knee joint. And then we start to close. We basically bring this back together and we run a running suture up that layer, and then we continue to close this in layers all the way to the outside. We don't typically use any sutures or staples on the outside. It's all underneath the skin, and then Dermabond or a glue on the outside, and then a waterproof dressing that goes on top of that so you can shower immediately. We've come a long way with surgery in the past 10, 15 years even, with smaller incisions, shorter hospitalizations. Even a lot of these can go home the same day, and usually a 4 to 6 week recovery depending on the patient. Thanks for joining us today. It's been a pleasure. If you would like to see us in the office, you can make appointments either online or by telephone, and we'd love to get you into the office and take care of you.
Great job, Brian. That was a great video. Showed a lot of good anatomy and a lot of the basics of hip and knee surgeries. We've got some questions coming in from the live feed, and we're wondering if a couple people could take these. Michael Bates, how about if you've tried exercise and it doesn't work for osteoarthritis, what other options should you try?
There are lots of things that we consider for knee arthritis. There's exercise, there's physical therapy. If you're a candidate to use a group of medications called non-steroidal anti-inflammatories, which we refer to as NSAIDs, then they can actually be quite effective for treating the pain associated with arthritis. Additionally, for a lot of my patients, we will try injections, whether that be what we call cortisone injections or what we call viscosupplementation, which is thick gel that adds lubrication to the knee. If we fail those conservative measures, then typically we will talk to individuals about knee replacement. But I would estimate that approximately 80% of my practice were able to treat the symptoms of arthritis of the knee with conservative measures and reserve surgery for the 20% of people or so who are starting to have trouble with basic everyday activities, walking upstairs, sleeping at night, playing with grandkids, all those things that take a big hit to quality of life.
And we have another live question coming in. It said, I've heard with total knee replacement surgery, the recovery is easier and faster than other types of knee surgery. Is that true? Can we get a couple comments from Dr. Prater and then Dr. Henderson after that?
That's I would say that's a difficult question because it kind of depends on what the knee surgery is. If you're talking an arthroscopic surgery where you just go in for a meniscal trimming or something, I would say probably not. But if other traumatic type injuries to the knee, then the answer is yes. I think it probably falls somewhere in the middle if you look at the whole spectrum of surgeries that can be performed on the knee. People get up, get moving really quickly, not quite as fast as a hip, but still, I get my patients up, get them walking the day of surgery. I usually tell people it's kind of the rules of two. You got 2 days of kind of being a little sore and stiff. 2 weeks, I'm going to kind of have you up walking around pretty good. And about 2 months, most folks are back to their pre-level or their pre-surgical level of activity.
And what do you think about that, Dr. Henderson? Can you add to that, or what are your thoughts on that topic?
I think I would echo what Dr. Prater has to say. I think in general terms, knee replacement is a significant operation and it takes some time to recuperate. It is also a tremendously successful operation, but realistically, the first few weeks after a knee replacement do take some effort and some therapy and some pain control. The folks on this panel, if you're comparing hip replacement versus knee replacement, I think we would all agree hip replacement is a much smoother recovery for many patients, but both groups of patients generally do very well when it's all said and done.
Great answer. We have another hot topic here. They said is hip replacement outpatient surgery. What do you think about that, Dr. Curtin?
So across the market, you're starting to see a big push to move patients into the outpatient surgery centers, which I think is a good thing. It's potentially safer for the patient in terms of not having to come into the hospital. They can go home and sleep in their own bed. I probably do 20 to 30% of my joints now for hips at the outpatient surgery center. I think they get in and out quicker. I think it's a safer environment for them overall. And I think patients are asking for it at this point. They don't want to come into the hospitals and they want to get up and get moving. And if they're a healthy, safe patient to do this, I think it's an excellent option for them. If I wanted my hip done tomorrow, I'd have it done in a surgery center.
Excellent. And how about you, Dr. Bates? What do you think about the outpatient surgery for hip replacement?
I agree completely. I think for the healthy patient that has minimal medical comorbidities, it's absolutely the direction that we're going. Like Dr. Curtin, at least a third of my practice is outpatient at this point. Patients are doing wonderfully. It's much better to sleep at home the night of surgery in your own bed than to sleep in a hospital bed. It saves people money. And importantly, we keep you from being around sick patients who may be in the hospital for medical reasons like pneumonia or infection. So I think it's definitely a
hot topic here about hip replacement, and we're going to ask about anterior versus posterior hips in the approach. Can we take a panel and say who does what approach and why?
Sure, I'll start. I was trained both ways, that's posterior or anterior. Currently in my practice, I'm probably 95% anterior hip replacement. I certainly have noted anecdotally, at least, that folks get up quickly. They're able to discharge home within hours of surgery. And the benefits on hip stability give me a lot of confidence to allow the patients to speed up their recovery without many limitations. So probably 95% of my primary hips and about 50% of my revision surgeries have been doing via the anterior approach.
How about you, Dr. Curtin?
I'd echo the same as Bates. I do probably well over 90% of my hips do an anterior approach. I've been trained on both, and I definitely see a difference in terms of the smaller incision for an anterior approach, stability purposes, and I think they just get up and get moving faster. Patients that have had a posterior approach in the past that have an anterior approach in my hands or some of my partner's hands will tell me that it was a faster, easier recovery through an anterior approach. So that's my my gut feeling is that it's an anterior approach in my hands is the better option to go. But I definitely know posterior approach surgeons that do an outstanding job and I mean, have outstanding outcomes. So it's hard. It's a tough debate right now.
Dr. Henderson?
Yeah, I don't want to sound like a broken record, but I would echo what the previous two said. So trained on both approaches, have chosen both based on my own experience and what I'm comfortable with in the operating room to do about 90% of my first-time hip replacements as anterior approach. I would echo that I think patients get up and get moving and seem to be pretty happy, but I would also echo the sentiment that hip replacement can be done safely and very well from any number of surgical approaches. I just happen to agree that I think anteriors do a little bit better.
Okay, another question. What is the typical progression of activity level for total knee replacement? And really, what's the importance of having activity on that joint? It's hard.
Should I take that question or?
Is that going to, let's send that to Dr. Henderson.
So progression of activity after knee replacement comes in stages. I think that the 222 moniker is a good way to think about it. The first few days, you're very stiff and you're just working to walk comfortably. Over the next few weeks, we're trying to get you basically from an assistive device like a walker down to a cane, and then from a cane to walking more normally without an assistive device. After about 2 months, we sort of release the reins a little bit. Long-term activity, is activity on a knee replacement good? Yes, it's actually vital to it lasting a long time. It keeps your muscles strong, it keeps your weight down, it keeps your cardiovascular health. This is, always comes back to the notion of this is a quality of life surgery done to get people moving, and the patient doing their part and staying moving is a big part of that equation.
Thank you for that answer. How about bilateral hips or bilateral knees? What are the indications? Is it okay to do? Is it not okay to do? Who would you do it in if it were a case? Let's go to Dr. Prater, followed by Dr. Curtin.
So we'll start off with bilateral hips. Is it indicated? Yes. I think kind of with bilateral hips or knees, the key is picking the right patient. Obviously, it's more surgery, it's more time in the OR, it's more blood loss, so it is more taxing on the system versus a unilateral approach. As far as when is the best time to use it, I kind of think about the same for both hip and knee. If someone has a horrible contracture on both hips, it's pretty much impossible to do one side and expect them to have any mobility whatsoever if the other hip is still horribly contracted. So I will typically, prefer to do both of those at the same time, and somewhat of the same with knees. If someone has horrible contractures and they just can't really mobilize if they only have one knee that's working. But the big determinant for me is really their overall health.
All right, to you, Dr. Curtin. What do you think about that?
Similar. I probably do one bilateral hip and one bilateral knee a month, maybe 2 bilateral knees a month. And it all goes to how they're going to rehab the knee or their hip afterwards. If they have 2 really bad knees and they're not going to be able to get up and get moving and do their therapy, or they're going to end up with they're going to stress their new knee and end up with a contracture of that knee, trying to compensate for another bad knee on the other side. Those are the patients that I'll take to the operating room and do both at the same time. They just have to know that it's a bigger surgery, it's a bigger hit. With knees, I usually say it's a 6 to 8 week recovery on a standard primary, and if you're doing both, it's probably closer to 8 to 10 or 10 to 12 weeks. Knee or hips, they tend to bounce back pretty quick. Maybe one more night in the hospital, but they bounce back pretty quickly even after bilateral hips. So it is more blood loss though. 2 surgeries, a little longer anesthesia time. But they have to understand that there's a little bit more risk and a little bit longer recovery time.
Great. When we start to look, there's a few questions about age. Is there anything age-related with a joint surgery? How late in life should one get one, or is there an age limit where beyond a certain age you would not do surgery. What do you think, Dr. Bates?
Yeah, so age is it's an important factor. I think, especially on the hip side, with the improvements in the polyethylene component over the past decade or so, we really don't worry about age nearly as much. The wear on the polyethylene has been reduced so drastically that it allows us to offer the surgery to people at younger ages. Essentially, if a person is suffering and can't sleep at night and they're 55 years old, I think we have enough confidence in our implants now that we would offer them that surgery, whereas 15 to 20 years ago we may have hesitated. So age plays a role, but there's no limit, and older patients are candidates as well.
Great answer, Dr. Bates. We've got an important question directly texted to the host of the show by an important 12-year-old that says, is there anything people recovering from a knee should not do? Can we get that answered from Dr. Henderson?
I would answer that in a couple ways. Our goal for a patient for the first few weeks is to protect the wound and to get it to heal. So that would be, we would do anything and everything necessary to keep the patient from falling if possible. Longer term though, which I think is sort of the thrust of the question, can you, for instance, run or what sort of activity limitations? The truth is I don't actually tell patients there are certain things they cannot do. I would say anecdotally, the biomechanics of a knee replacement are such that very few people really get back to running, like long distance running in particular. But I mean, if a patient is able to do it, things like skiing, golf, doubles, tennis, I don't consider any of those out of bounds.
All right, great answer. The question that we have that's coming up a few times is they're looking at the issue of physical therapy, and is whether physical therapy should be used before surgery and the role of physical therapy after surgery with respect to both hips and knees. Could Dr. Prater take that question?
Yeah, so we call it prehab, I guess is the kind of the term we like to use, and I think that it actually is one of the things that's very beneficial. The number one determinant for how much motion people get, particularly with knee surgery after surgery, is their motion before surgery. So if anyone has a stiff knee on the front end, I'm a big proponent of trying to get them in therapy to get that knee moving before surgery. Hips can be the same way. There's still even more studies coming out now showing that how therapy is one of the more effective treatments for hip and knee arthritis. So yes, it is. It can be very helpful. Five-year-old.
Great. Another call in to piggyback on that, Dr. Prater. Someone called in or wrote in. They asked they'd like to keep playing baseball, and they're asking if the knee will have more than 90 degrees range of motion, and if sliding is still okay.
Who is that going to?
Oh, that's going to Dr. Prater. I asked Dr. Prater to continue on with that. I apologize.
Was that directed to me?
Yes.
Yeah. Sorry, I had a little bit of mishap there. Yeah. My goal range of motion is 130 degrees on my knees. And
A little delay, sorry.
no, you're fine. I had a 5-year-old try to sneak in here on me, and I was shooing him away. So Bates was right. He did call out that I would be the first one to have it happen. So yes, my goal motion is from 0 to 130 degrees on my knees. So I would hope that it would be able to at least get 90.
Great. There's another question that came in that's interesting. It's important for us to hear. They're asking about, do we ever diagnose bone tumors or other type of soft tissue tumors with what we see in the hip and knee, and what to do about that? Dr. Henderson, could you answer that question for us?
Yeah, it's a good question. So I would say, my practice, like many others, 95% of what I see is degenerative disease. It's arthritis or rheumatoid arthritis or sort of chronic, slow acting joint wear and tear. Once in a while, all of us will see, myself included, something show up on an x-ray, something that is of concern for, something much more concerning like a mass or a tumor or a cancer. Clues you get from a patient that would suggest that would include a history of cancer, the patient perceiving the development of a mass. Certainly if you see anything on an x-ray or if you happen to have additional imaging of that hip or knee, those are things we do see, and they're important to find, because if in fact you have that sort of an issue going on, then the treatment for it is much, much different than the majority of what we're speaking about tonight, and elective joint replacement, et cetera. So the first step when you're concerned about a mass or would be trying to get a diagnosis. So we do see it from time to time. I think most of us send that sort of a patient or help them get arranged to have a consult with sort of someone who specializes more in the orthopedic mass or tumor sort of practice. But it's something any sort of orthopedist or frankly any physician needs to keep their guard up for sure.
Should I get up?
Great. I think that reiterates that we see folks all the time for different kinds of issues, and oftentimes we do pick up on things that aren't expected. And when that happens, we've got a bunch of local experts here in the Charlotte area that can help take care of that we get you to in the if that need ever arose. And so when we look now, we have an important question that's coming up from about antibiotics. People are inquiring about whether you should take some antibiotics before dental work done. And I was going to get the panel to see where everyone stands on that. Dr. Curtin, what do you think about antibiotics before dental procedures? Do you believe in it? What's your protocol? How long do you do it?
So at the Hip and Knee Center downtown, we've kind of come to the agreement that we do lifetime antibiotics postoperatively. There really isn't a lot of data on this at all. I know the dentists and their groups, associations have basically said that they don't support it because there's no data behind it. A lot of this is just anecdotal. We've got partners here that have been in practice for 30 years. They've got a patient that's had a perfectly performing hip or knee for 10 years, and they get their dental work done, and a week later they've got an infected knee. It's all anecdotal in terms of are they correlated or not. And then there's always the other side of it. Are we promoting antibiotic resistance by doing this? Typically, with an antibiotic prophylaxis prescription, you're getting one dose right before you go to the dentist. It's not a prolonged course of 7 to 10 days, like you would get for a sinus infection or something. So I don't think that we're promoting antibiotic resistance by doing this, but I think it's sort of better safe than sorry. If you miss a dose, I don't think it's the end of the world. Your risk is ridiculously small of getting an infection after dental work, but it's a couple pills before you go. I don't think it's a big deal, and that's our stance here at the Hip and Knee Center, is that everybody gets prophylaxis for lifetime.
Great, excellent. We appreciate that, Brian. Thank you so much for that answer. Now we're going to come over to Rachel, and she's going to show us some of the work that she does here. We're going to take a break from the questions, and we'll have her show some of the work they do out here at Experience Anatomy.
Yeah. So here at Experience Anatomy, we use plastinated specimen, which are true human specimen that have been preserved through a process called plastination. So in front of us, we have a few specimen here. Here's a hip joint. You can see the actual cartilage that covers the ball of the femur here. And when you need a hip replacement, this is the tissue that is damaged. And as mentioned earlier in the video, here's a cross section through the hip joint, and this part is replaced as well as this part of the pelvis. So this is the area where you will have new replaced material in the hip joint after a hip replacement. Also as shown already, that allows your range of motion to increase. So you can do internal and external rotation and move that hip joint more easily and pain-free. As far as the knee joint goes, we have a knee specimen here, which has been dissected to show the actual joint. If I bend that joint, you can see the ligaments in here. And this is the ACL and the PCL. And I saw a question roll in that asked if the ligaments stay intact after a knee replacement, and they actually don't, right?
Well, it depends. So there's a couple different ways. We keep the inside and the outside ligament, the MCL on the inside we keep, and we keep the LCL. We usually take out the ACL. However, there's two versions of knee replacements. One of them keeps the posterior cruciate ligament, and another model takes the PCL out. And so those are usually surgeon preference as to what one of those models they use, or what one of those type of knee replacements they use with respect to the PCL. So we really want to preserve that outside and that inside ligament. However, we take out the ACL and the PCL in the middle, and that's replaced by some mechanisms within that design of the knee replacement that helps to serve that purpose.
Right, so the knee will still be stable even with those ligaments removed after surgery. The knee joint really is just a stacking of the bones. So you can see how the femur and the tibia line up. The femur really isn't staying, can fall off easily. And that's what a meniscus does, is it serves as a way to balance that femur on top of the tibia. What happens to the meniscus after a knee replacement?
Well, we take the meniscus out. So as part of cleaning out the knee in order to prepare those surfaces. So in Dr. Curtin's video, he showed how we're actually just putting a cap on the top of the tibia. So the meniscus are both C-shaped pieces of cartilage within that knee. So you no longer need those as part of that replacement. So as we make a horizontal cut across the top of the tibia, those are removed prior to that cut or after that cut in order to clean the knee and make room for our implants.
Great.
All right. We're going to go back to the panel for another series of questions that are coming through via the chat room. All right, we're back to the questions. What questions do we have coming through, folks? Are there any non-surgical techniques for the management of hip and knee arthritis? What would you do before? So if someone came in and they're having moderate symptoms, not ready for a knee replacement, what are the options that you first go down? Dr. Bates.
Yeah, lots of things we're going to try. It can be something as simple as ice or heat application, physical therapy, as was mentioned previously. If that's ineffective, then we'll typically try some medications called anti-inflammatories and so forth. We can try braces, and usually injections are the last step before we start thinking about surgical intervention. If injections are ineffective, then I will talk to my patients about considering surgery.
Great. There's a lot of questions about the progression and what the cartilage does and what happens to the cartilage as arthritis progresses. Can Dr. Henderson take that question, actually describe what cartilage is, what happens to it as the arthritic process begins and as the arthritic process continues on?
Yeah, it's a good question, and it's not always intuitive, but cartilage is the smooth, low friction covering at the end of our bones, and that serves the gliding surface of our joints. So that's every joint in the body, your hips, your knees, your shoulders, your fingers. It is what allows us to move around in the world without the pain of doing so. And as you get arthritis, the cartilage wears out. And I think the analogy was used earlier in the video, and I would agree with it, very much like wearing tread off of a tire. It can start to wear out for a lot of reasons. It can wear out because of trauma, or because of meniscus tears, or because of genetics seems to play a role. But once it starts down the path of wearing thin, it's a gradual progression for most patients, from healthy cartilage, no pain whatsoever, over time getting some early symptoms, ending up at sort of a diagnosis of arthritis like we're talking about this evening. When it's completely gone or eburnated off the bone, that's when we start using phrases like bone on bone. That's just a term we will throw around in our office indicating advanced or sort of end stage arthritis of a given joint.
Great. And Dr. Curtin, we're getting some questions about bone spurs. Could you describe what a bone spur is? Is it worthwhile taking a bone spur out on its own? What bone spurs look like and what they do and what role they serve in the arthritic knee or hip?
So bone spurs or osteophytes are just extra bone and calcium that's put down around the rim of the joint surface itself. And it's a way that your body responds to altered forces across that joint. It tries to distribute the surface area a little bit differently for that force. Typically, unfortunately, it does decrease range of motion of the knee with these bone spurs, and they irritate the soft tissues. So when you move the knee and those bone spurs are underneath the soft tissues, they cause inflammation and irritation of the soft tissues. Back in the 80s, when arthroscopy became very popular, it was sort of the insurance companies were like, hey, let's try and take down these bone spurs, and they were paying for it. And a lot of the sports guys would go in and scope these knees, take down the bone spurs. And unfortunately, 6 months to a year later, those bone spurs would come right back because they weren't actually doing anything to adjust the mechanics or fix the cartilage in the knee itself. So it was a short-lived procedure. It didn't last very long. And now it's not something that's recommended, and insurance companies don't pay for it. So just removing the bone spur is not going to fix the problem.
Excellent. And we're getting some questions a lot about exercise. Could Dr. Bates, could you talk about exercise, whether before surgery, after surgery? Does it play a role in benefiting us for the folks who have an arthritic hip or knee?
It does, absolutely. That's the whole benefit of the prehab or doing physical therapy before surgery. If it's the knee, one of the challenges that we have after surgery is the rehabilitation of the quadriceps. One of the ways to improve that process is to start that rehabilitation prior to the surgery. Strong quadriceps make recovery from knee surgery much more straightforward for people. The same thing for the hip. You have to think about the fact that folks that have severe arthritis are in pain, therefore they limp. They don't use their joints in the standard fashion, so the muscles become weak over many years. After the surgery, the pain is gone, the motion is better, but it takes a lot of time to rehabilitate those muscles. So that's a key part of what we're doing before and after surgery.
Great. And we're going to wrap up with one more question. And the question's coming about stem cells. What is the role of stem cells in arthritis? Is there data behind the use of it? What kind of stem cells are there? Where do they come from? So could we send that to Dr. Henderson?
Yeah, so I probably get this question once or twice a day in my office, and I'm happy to address it. Stem cells are probably coming as a therapeutic. I think it is safe to say they are still very much experimental. Stem cells, the basic concept is these are the cells that are the precursors of the different parts of your body. So it includes your joint and your cartilage. They can be harvested from any number of places like your bone marrow or your peripheral fat tissue, but they do have to be pulled from somewhere in your body, and that's a procedure in and of itself. They're often then sent off to a lab through kind of a complex process, to be honest. It's a little bit labor intensive, a little bit costly, just to be honest. And then they're injected into the joint typically. It's an evolving field, rapidly evolving, but my best statement about the role of stem cells in the treatment of arthritis at this point in 2020 is that it's experimental. I don't recommend for it for patients. I don't begrudge people who want to try it, but I don't think we're there yet is my best answer.
Great. Well, that was our last question for the night tonight. We want to thank everyone for coming. I want to thank everyone for coming, joining into the internets for us. Dr. Bates, Dr. Prater, Dr. Henderson, and Dr. Curtin, we appreciate your time. Thanks for taking some time out of your day to help everybody out. We hope this information was found useful for you guys. We hope if you have any questions, obviously contact us through the internet, all of our sites. We have Instagram, Facebook. Call the office. If you feel like you need to be seen, call one of the North Carolina offices. We have how many offices, folks? 43 office locations around Western North Carolina, part of Middle North Carolina. So be sure to call if you have any concerns, worries. Call the office, come on and be seen so we can help take care of you and try to make your lives better. So our next event is July 16th for spine. We'll have some spine surgeons on the internet to answer your questions, go through a very similar process, showing you some anatomy, talking about spine surgery, issues that folks may have with their spine, such as discs, fusions, and other things like that. So if you like what we saw today, smash the like button, 2 thumbs up for the North Carolina YouTube site. We appreciate you, and have a good night.
Thanks for joining us here at Experience Anatomy. If you have any specific anatomy you'd like to see, please comment below so that we can try and have that here for you. Oh, and you can also visit us at experienceanatomy.com.